Hello and welcome again. I am Dr. Erkan Duman. I will talk about PPB for tractional retinal detachment today. DR is leading cause of new blindness in patients aged between 20 and 75 years old, whole of the world. DMA is responsible for 75% of DR-related vision, as you know. Vision loss in other 25% of patients with DR come from complications. Which are these complications? Vitreous hemorrhages, TRD, epiretinal membrane, combined TRD and RRD. TRD pulls the neurosensorial retina away from the retinal pigment epithelium. This detachment can involve the macula, causing severe visual acuity loss. Before surgery, careful coordination with other branches mandatory and important to manage to reduce complications during the surgery. And VEGF application may also stabilize the DR and allow surgery to be done more easily. But the primary goals of vitrectomy are to clear medial opacities, relief of vitreoretinal tractions, and stabilize the proliferative process. A TRD that has recently involved the macula continues to be the most common indication for vitrectomy, and despite improvements in instrumentation and techniques, it remains a challenging surgery. The most frequent indications for vitrectomy in patients with PDR include non-clearing vitreous hemorrhage, TRD, combined TRD and RRD, and neovascular glaucoma. Purpose of vitrectomy in PDR include removal of vitreous opacities, removal of posterior hyaloid, release of retinal tractions, retinal reattachment, treatment of retinal ischemia, prevention of fibrovascular proliferation. Now we will see small examples for all these steps in short videos. As you see here, there is a moderate vitreous hemorrhage and present PVD also. We are starting our surgery by removing that vitreous opacities to visualize the surgical field. After clearing that opacities, we will go on for other steps. Removal of posterior hyaloid is second crucial step in diabetic surgery. If you manage to clarify the surgical field and provide a good view of the retina, you can try to lift the posterior hyaloid. As you see here, we are using cutting probe to remove the hyaloid. Another example for PVD induction. The hyaloid is being removed from optic nerve. Yes, we catch it and lifting it. Now, we will change our lens to wide field one. Yes, we are doing it now. Again, we are focusing on the optic nerve. We will catch it again and lifting it to pars plana, and we are going on our surgery. The third step is releasing anteroposterior tractions. In DR patients, posterior hyaloid is usually detached in the periphery. So you have to remove, first you have to divide the hyaloid in two parts. Yes. I have especially chosen this case to show you how critical step is this. This is an advanced diabetic case. If you jump this step in this kind of cases, the surgery will become impossible after a while. You have to complete this one 360 degree. There is three procedures for releasing the traction in PDR cases: segmentation, delamination, and in-block excision. You will see the first one, segmentation. There is a huge membrane which is covering the whole of the central port, and we are segmentating and making it smaller. This is another example for segmentation, but the main difference in this one is usage of the cautery before segmentating the membrane. If you know when you have to use that tool, it can provide big benefits during the surgeries. For example, in this video, the membrane is very close to retina, but after right cautery application, the membrane becomes smaller and leaving from its place. Now we are segmentating it again. Yes, we have finished segmentation side. The second way to release the traction is the delamination technique. If you segmentate and make this kind of membranes a small part, you can remove them by your cutter probe. We call it as a delamination technique. In the same case, we are doing two simple examples for that step. Yes, again, we are holding the small part of that membrane. Again, we are lifting it. Then we are going on with delamination. If you are using mono-manual technique, this is a very beneficial one. The third way to release the traction is in-block excision for the membranes. For this procedure, you have to use your both hands. In any cases, you can apply this technique. If you are experienced enough, it can work in your hands very well. As you see in this video, I am holding the membrane with my right hand with jaws forceps, as you know. In my other hand, the scissors, and sometimes I am cutting the membrane. One tool, but for different usage. Sometimes you can use it as a blunt dissector also. Now we are nearly finishing the first part of the membrane. It becomes bigger. In this video, I'm performing it under BSS, but you can also perform it under perfluorocarbon. Now we are cutting again. While doing it, you are always lifting the membrane, but you are not using big force. If you feel that you can relieve it not by cutting, you can dissect it also. Now the membrane becomes very huge, so you have to make it smaller by your cutter. This is the last part of the membrane. Again, the same maneuver, cutting, dissecting, and the last cut is coming. Yes, it has been relieved from retinal surface. Now we are removing it by our cutter. After removing all membranes and finishing our work, you can also peel ILM. There is no consensus, as we see before. In the previous presentation, they have talked about it. You don't have to do this step. It depends on your experience.
1 minute, please.
Okay.
Erkan.
Sometimes even you remove all membrane, you couldn't attach the retina because of shortening or tightening. If so, you have to perform retinectomy. After removing all tractions, we are applying retinectomy in here. We are using our cutter to do retinectomy. Before we have already done cautery. Now we are removing the anterior part of the retina. This is a crucial step. You have to remove all these anterior flap to prevent any hypotony that will exist in future. Then you can use perfluorocarbon and attach the retina again. After removal all tractions and relaxing the retina, you have to perform a peripheral vitreous shaving. It needs a scleral depression. You can perform it by yourself, or you can take a help of your staff. If you are using 3 trocar, it has to be done by another one. If you are using 4 trocar, you can do it by yourself, as we know. And the last step is laser. To prevent any ischemia, you have to perform laser after finishing your works, and you have to complete it 360 degree. As in all surgeries, diabetic surgery includes a lot of complications, but the most common are bleeding, iatrogenic breaks, and sclerotoma-associated complications.
Time is over, please.
Obeying the rules in diabetic vitrectomy and applying all the steps one by one can prevent any complications. My take-home message: before you focus on the problem at the central pole, you have to prepare the peripheric retina to allow you to solve the problem at the center. Thank you.
Thank you very much, Erkan. Very nice video. I just want to ask you about the recent management of vitreous hemorrhage in diabetics, because in the old days we used to wait for
I
3
couldn't
months
understand.
in.
Excuse me, I couldn't
insulin.
understand you. Can you? Can you?
I'm asking you about the recent management of vitreous hemorrhage.
Vitreous hemorrhages?
Yes, in diabetic. Because in the old days we used to wait for 3 months in insulin dependent and even 6 months in non-insulin dependent. Nowadays, what's your timing of vitrectomy and vitreous hemorrhage?
When I see any vitreous hemorrhages, if he or she is not diabetic, I'm becoming very excited because you don't know what will exist during the surgery. But if he is or she is a diabetic patient, I become relaxed because usually the vitreous hemorrhage is coming from the hyaloid detachment. It there is usually you can see the present PVD in vitreous hemorrhages in diabetic patients. So if I could be sure about that, I'm never changing my surgical approach. I'm always starting with peripheral vitreous and especially choosing the nasal side, because if you couldn't know, if you do ultrasound before surgery, we have to do it because we have to be sure about detachment. I'm always starting with nasal side. I'm opening a small hole in the nasal side. If there is present detachment and you have already missed it, there is no risk before you are on the nasal side. And you can manage that problem. And if you clarify the retina, then you can go on peripheral vitreous, dividing the peripheral vitreous, and you are slowly, gradually going to the central part, and we are removing all the vitreous.
Thank you, Erkan. Now the question is for the panelists.
For me, thank you for your beautiful presentation, by the way, but for me in a vitreous hemorrhage, especially type 1, I didn't wait anymore. When I see a type 1 diabetes presenting with the vitreous hemorrhage, whatever it's mild, moderate, severe, any degree of vitreous hemorrhage, I will go with vitrectomy. I was very aggressive in treatment of type 1 diabetes. I am very aggressive in treatment of type 1 diabetes. Again, I am very aggressive in treatment of type 1 diabetes.
I want to add another one.
Yes.
In my opinion, you couldn't find this information in any books because it's not suitable to write this one. If I could manage all the diabetes type 1 in the whole of the world, whenever I see that patient at first time, I will apply 360-degree laser. Before doing anything. Really. But as you said before, they are coming us and with a big problems. If I see any type 1 diabetes, I don't want to do anything. Really. I know all of us on the same mind. Yes, but you have to do something.
Well, yeah, I mean, evidence-based medicine says that early vitrectomy, there's a huge study, and early vitrectomy for type 1 diabetics is more beneficial than type 2 diabetics. Like a decision to go to vitrectomy for type 1 diabetics. Well, I mean, 2 weeks, okay, 2 weeks.
2 weeks. But it's meaning immediate intervention. 2 weeks, 1 week, 5 days. It's just preparing your patient.
Yes.
But didn't decide with a type 1 diabetes for just follow.
Another information. Yes, it has been written. There is no problem. If you do any injection before surgery, you are imagining that it will help you during the surgery. But there is some bad cases that suddenly decreased VEGF level can cause crash syndrome. And it's tightening, shortening the retina. Then the last case that I have done retinectomy, that was one of that examples. It was a 36 years old poor guy, never treated by anything, and he comes to me about 5% vision. I have applied anti-VEGF and didn't examine that patient before surgery, at the day of the surgery. When I get into the eye, it was very late to escape.
Dr. Erkan, do you inject your all patients before surgery?
No, it depends on the situation. It depends on the situation.
What
But
type of VEGF you use to inject?
Which one?
What type of VEGF, of anti-VEGF you use to inject?
It's forbidden to inject Avastin in here. It is forbidden. Because of that, you have to use that licensed one, Lucentis or Eylea.
Thank you very much. Thank you for all. Thank you for the speakers, for the panelists, and for the audience. Now, a lunch break.